Imagine taking like a really deep, satisfying breath. You feel your chest expand, the cool air rushes in, completely filling your lungs.
Right. It's a great feeling.
Yeah. But now imagine trying to let that air out, but your lungs feel like, I don't know, like stretched out, heavy plastic bags that just refuse to snap back.
Oh, that sounds awful.
It is. The air is trapped. You try to take another breath in, but there's literally no room. So you are essentially suffocating while your lungs are entirely full.
Which is an incredibly terrifying concept.
Right. And today, we're doing a deep dive into the relentless mechanics of a disease that does exactly this. But we're also exploring how patients are fighting back against a medical information system that honestly often speaks a language they just do not understand.
Yeah, that's a huge part of the problem.
It really is. And our stack of sources today is pretty unique.
Wow.
We aren't looking at some impenetrable medical journal. It's actually a foundational text from the editorial and medical research team at the independent platform iMedix. It's titled Breathing Lessons, the iMedix Guide to Understanding COPD.
And that is such a profound starting point, because the reality of chronic respiratory decline is something most people simply cannot conceptualize until they're right in the thick of it.
Definitely.
We just take the automatic background operation of our biology completely for granted. But when you get diagnosed with a chronic progressive condition like COPD, that invisible machine becomes incredibly painfully loud.
Yeah. Every single breath transitions from an unconscious reflex to, like, a conscious, exhausting effort.
Exactly. So our mission in this deep dive is to explore the clinical realities of COPD. What it actually is, how it ravages the body, and how it differs from other respiratory issues.
Right.
But we are also zooming out. We want to examine the meta level here.
Yeah, the bigger picture.
We're going to deconstruct the philosophy behind this specific guide and the platform that built it. Because in a landscape that's just defined by absolute information overload, having an independent, reliable compass is honestly just as critical to your survival as the medical data itself.
Okay, let's unpack this, because finding that safe harbor of information, that is the ultimate shortcut to being well-informed, especially when you are suddenly thrust into the terrifying territory of a new chronic diagnosis.
Okay, absolutely. It's overwhelming.
I want to start by looking at the specific title of the document from our sources, Breathing Lessons. It's striking, isn't it?
It really is.
It doesn't sound like the clinical pathway for managing pulmonary obstruction. It sounds human. It almost sounds like a novel or, a memoir.
And that framing, it's profoundly intentional on the part of the iMedix editorial team. When they title it Breathing Lessons, they are fundamentally framing a chronic illness not just as a sterile clinical diagnosis residing on some specialist chart, but as a deeply personal lived experience.
Yeah, a lived experience.
It suggests an unsettling paradigm shift. Something you once did naturally, instinctively, from the literal moment you were born, breathing, now requires ongoing deliberate education.
Wow, yeah. It requires attention and adaptation. You have to relearn it.
Exactly. It shifts the primary focus away from the microscopic pathology of the disease, and it places it squarely on the daily reality of the patient who actually has to navigate life living with it.
It brings humanity back into a space that is usually just dominated by cold, hard jargon. And right out of the gate, the core focus question posed by the source material is incredibly direct. It just asks, what is chronic obstructive pulmonary disease?
Right, they establish a baseline.
Yeah, establishing that baseline. But let me push back a little here.
Okay, go ahead.
If I'm a patient who has just been told my lungs are failing, I'm terrified. I don't want a dictionary definition. I want to know how to fix it, right? What pill do I take? What inhaler do I use?
It's a very normal reaction.
So why is spending so much time on this what is question so vital? Why not just bypass the anatomy lesson and jump straight into the treatment protocols?
Well, it's a completely natural instinct to want to leap straight to the solution when you are in distress. Of course you do. But you cannot effectively manage, track, or treat a condition if you don't fundamentally understand the mechanics of what you are fighting.
Okay, that makes sense.
Establishing that baseline is crucial because COPD is wildly misunderstood by the general public. And even by patients who have literally just been newly diagnosed.
Really?
Oh, yeah. If you just take the pill without understanding the mechanism, you remain a passive victim of the disease. So to truly answer the question, what is it? We have to break down the acronym.
Right.
Because the acronym itself is essentially a roadmap of the pathology.
Well, let's do that. Let's break it down, because even the acronym feels designed to keep people at a distance. COPD.
Exactly. So let's demystify it. The C stands for chronic. Mm. This means it is long-term, persistent, and this is crucial to understand, it does not go away.
It's not a cold.
No, it is not an infection that you can just clear up with a quick course of antibiotics.
Okay.
Then the O is for obstructive. This means that the physical airflow in and out of the lungs is blocked. It's hindered or physically impeded in some way.
Got it. Airflow is obstructed.
Right. The P stands for pulmonary, which just refers specifically to the lungs and the respiratory system as a whole. And finally, D for disease, meaning it is a systemic pathological condition.
A deviation from the normal, healthy state of the body.
Precisely.
Which immediately brings up a point of massive confusion that the source material actually tackles head-on, and that's the conflation of COPD and asthma.
Well, this happens constantly.
I think a lot of people group them together. They think, okay, trouble breathing, wheezing, coughing, use a little plastic inhaler. It must be the exact same basic thing, just maybe a different level of severity.
Yeah, that's a very common misconception.
But the iMedix guide draws a very hard line between the two. They are fundamentally different beasts, aren't they?
They are entirely different in their underlying mechanics, their progression, and their ultimate prognosis.
Okay, break that down for us.
Well, let's look at asthma first. Asthma is primarily an inflammatory response. It's an overreaction by the body's immune system to a trigger.
Like pollen or dust.
Exactly. Pollen, dust, cold air, even intense exercise. When someone with asthma encounters that trigger, the smooth muscles wrapped around their airways spasm and constrict, and the airway lining itself swells up.
Right, closing off the tube.
But here's the critical distinction. Asthma is generally reversible.
Meaning you take a rescue inhaler, the muscles relax, and you just go back to normal.
Precisely. The bronchodilator opens the airways back up. The inflammation subsides. And importantly, between those asthma attacks, a person's baseline lung function can be completely 100% normal.
Oh, wow. So there's no lasting damage.
Right. There isn't necessarily structural degradation happening in the background with asthma.
Okay, so asthma is like an episodic spasm, a temporary closing of the door. How does that contrast with COPD?
COPD, on the other hand, involves chronic airway and lung damage that is progressive, relentless, and largely irreversible.
Irreversible. That's a scary word.
It is. The damage is permanent. You aren't dealing with a temporary spasm. You are dealing with the physical destruction of the lung architecture itself.
Okay, so when they use an inhaler.
When a COPD patient uses an inhaler, it might provide some symptomatic relief by relaxing whatever smooth muscle is still there, or maybe reducing some of the background inflammation.
But it doesn't fix it.
No, it does not reverse the core damage. The baseline lung function is permanently lowered, and without serious intervention, it just continues to drop over time.
So if asthma is like a temporary barricade blocking the airway, COPD is the road itself slowly crumbling away.
That is an excellent way to visualize it. The infrastructure itself is fundamentally compromised.
Well, let's get into the mechanics of that crumbling infrastructure, because this is where the guide really opened my eyes. It highlights that COPD isn't just one single thing.
No, it's not.
It's an umbrella term, right? And it usually encompasses two primary devastating conditions that operate simultaneously: emphysema and chronic bronchitis.
Yes.
I want to break these down so we really understand the physics of this disease. How does emphysema actually destroy the lungs?
To understand emphysema, we have to travel deep down into the microscopic architecture of the lungs.
Okay, I'm with you.
At the very end of your branching airway tubes, you have these tiny, delicate air sacs called alveoli.
Alveoli.
Right. And you have hundreds of millions of them. Think of them like incredibly dense clusters of microscopic, highly elastic balloons.
Okay, balloons.
This is where the magic of respiration actually happens. Oxygen crosses the thin walls of these balloons into your bloodstream, and carbon dioxide crosses back out to be exhaled.
And their elasticity is the key to making that happen, right?
Absolutely. When you inhale, your diaphragm pulls down, creating a vacuum,
Yeah.
and these millions of tiny balloons inflate. But exhalation, the act of breathing out, is largely a passive process.
Really? It just happens on its own.
Yeah, it relies on the natural rubber band-like elasticity of those alveoli to just snap back to their original size. That snap effectively squeezes the stale carbon dioxide-rich air out of your body.
So a healthy lung is like a brand new rubber band. You stretch it and it violently snaps back, What does emphysema do to that rubber band?
Emphysema is the systematic destruction of that elasticity. The delicate walls separating these tiny individual balloons are broken down and destroyed by chronic exposure to toxins.
Like cigarette smoke.
Primarily, yes.
Yeah.
So instead of a tightly packed cluster of 100 tiny, highly elastic balloons, the internal walls dissolve, and you are left with one large, floppy, stretched-out bag.
Ugh. So it loses its snap.
Exactly. It loses recoil. And because it can't snap back, the mechanical force required to push the old air out is just gone.
So the air gets stuck.
The stale air becomes trapped inside these floppy bags. When you try to take your next breath in, there is literally no physical room for the fresh oxygen-rich air to enter, because the lungs are already hyperinflated with trapped, useless gas.
Going back to my opening analogy, you are suffocating while your lungs are entirely full. That is just a horrifying biological reality. Your brain is screaming for oxygen, you try to inhale, but the physical space is occupied by trapped carbon dioxide.
It creates a sensation of profound air hunger. And because the walls between the alveoli are destroyed, you also have significantly less total surface area for that crucial gas exchange to occur.
Oh, right. Less surface area.
So even the fresh air that does somehow make it in, it isn't being utilized efficiently.
Okay, so that's the emphysema side of the equation, the floppy, useless air sacs. But you mentioned COPD as a dual assault. What is happening with chronic bronchitis?
Right. The second half of the disease.
Because bronchitis is a term we hear all the time. People get a bad cold in the winter and say, oh, it turned into bronchitis. But chronic bronchitis in the context of COPD, it has to be different, right?
It is entirely different in scale and permanence. If emphysema is the destruction of the air sacs at the end of the line, chronic bronchitis is the devastation of the highway system leading to the
highways.
Yeah, the bronchial tubes. It involves constant, relentless inflammation of the mucosal lining of those tubes.
And whenever tissue in the body is chronically inflamed, it swells up.
Right. So immediately, the inner diameter of these breathing tubes becomes narrower just from the swelling. But the real physiological nightmare is how the body attempts to defend itself against the chronic irritation that causes that inflammation.
How does it do that?
The lining of your airways contains goblet cells, and their job is to produce mucus. In a healthy lung, a thin layer of mucus is actually a good thing. It traps stray dust and pathogens.
Right, it catches the bad stuff.
But in chronic bronchitis, these goblet cells multiply and go into absolute overdrive. They produce a massive, excessive amount of thick, sticky, tenacious sputum.
So the highway is not only narrowed by swollen walls, it is completely congested by a massive overproduction of thick mucus.
Precisely. Now, in a healthy person, the body has a mechanism for clearing mucus. Your airways are lined with microscopic hair-like structures called cilia.
The biological brooms.
Yes, exactly, the brooms. They beat in a synchronized upward wave, constantly sweeping the mucus layer and whatever trapped debris is in it up out of the lungs toward the throat.
So you can unconsciously swallow it or cough it out?
Right. It's an elegant, continuous escalator of self-cleaning.
Is sense a but coming? What happens to the brooms in chronic bronchitis, particularly when we factor in the primary cause of COPD? Because the guide makes it painfully clear that smoking is the overwhelming risk factor here.
And this is exactly where the mechanics of cigarette smoke become incredibly destructive. The thousands of chemical compounds and toxins in inhaled smoke, they don't just irritate the airways, they are actively toxic to the cilia.
They poison the brooms.
First, the smoke literally paralyzes the cilia, stopping the sweeping motion. And then over time, with chronic smoking, the smoke literally burns them away and kills them. The brooms are just gone.
That's a catastrophic failure of the defense system. I mean, if the goblet cells are in overdrive, producing massive amounts of thick mucus because of the smoke irritation, and the cilia are dead and paralyzed so they can't sweep it out, where does all that mucus go?
It doesn't go anywhere. It pools. It sinks down into the lungs and stagnates in those narrowed, inflamed airways.
Woo!
And warm, stagnant, sugary mucus is the absolute perfect breeding ground for bacteria and viral infections.
Which leads to more respiratory infections,
Yes.
which causes more inflammation,
Exactly.
which triggers more mucus, which damages more lung tissue. Wow, it is a vicious, inescapable feedback loop.
It is. So when we define COPD, you're often dealing with a patient who has floppy, hyperinflated, inelastic air sacs from emphysema and the narrow, swollen, mucus-choked bronchial tubes from chronic bronchitis, both simultaneously.
The dual assault. That perfectly explains the clinical symptoms the guide outlines. Let's map those symptoms to the mechanics because suddenly they make total sense.
Let's do it.
The chronic hacking smoker's cough that produces like a quarter cup of sputum every morning.
That is the body desperately utilizing the only mechanical force it has left to clear the massive pooling of mucus because the cilia are dead.
The cough has to do the job of the paralyzed broom.
Yes, it's a violent secondary mechanism trying to compensate.
And the breathlessness, the extreme exercise limitation.
That is the loss of alveolar surface area and the lack of elasticity. The body simply cannot physically pull in enough oxygen or expel enough carbon dioxide to fuel the muscles during exertion.
But here is the tragedy that the iMedix guide points out, and it's something that feels so deeply human and flawed. Early disease is massively underrecognized.
It is.
The symptoms creep up on people, a nagging cough, getting a little winded, walking up a slight incline to the grocery store, needing to sit down after carrying the laundry upstairs. And what do people do?
They rationalize it.
Right. They say, oh, I'm just getting older, or I've put on a few pounds, or I'm just a little out of shape.
And that rationalization is a fatal psychological trap. It is incredibly common, and it is devastating. By attributing early, subtle symptoms to the natural aging process or lack of fitness, patients unwittingly delay seeking a proper medical evaluation.
They just adapt.
Exactly. They adapt their lifestyle to the disease without even realizing it. They stop walking up the hill. They take the elevator instead of the stairs. They shrink their world to accommodate the declining lung function.
Which means by the time the breathlessness becomes severe enough to genuinely frighten them, right? By the time they're struggling to breathe while simply sitting in a chair and are forced to go to a doctor,
they've already lost a massive, irretrievable percentage of their lung capacity. The structural damage of emphysema and the chronic changes of bronchitis cannot be undone.
You can't unpop a balloon.
Exactly. The goal of medical intervention at that lead stage is merely to slow the decline and manage the severe symptoms, not to cure the disease. Early intervention is everything, which is why dismissing a chronic cough is so incredibly dangerous.
Let's put ourselves in the shoes of that patient for a second. The rationalization failed. The shortness of breath became undeniable. You go to the pulmonologist, and you were officially diagnosed with COPD.
Okay.
Suddenly, you are dropped into a foreign country where you do not speak the language, and the medical system is not designed to be a gentle tour guide.
No, it's really not.
They throw around terms like FEV1, which, full disclosure, I had to look up. It's forced expiratory volume in 1 second, essentially how hard and fast you can blow air out.
Right, it's a key metric.
They talk about exacerbations, they talk about spirometry tests, and you, the patient, are just sitting there on the crinkly paper of the exam table, terrified, trying to remember how to take your next breath. The jargon is a literal wall.
It is entirely alienating. The medical language is designed for precision among professionals. It's not for clarity for the terrified patient.
Which is why a foundational guide like breathing lessons is so crucial. It acts as your phrasebook in this terrifying foreign country.
Yeah.
It decodes the FEV1 and the emphysema. But let me challenge this entire premise for a second.
Okay, what's your challenge?
If I hand you a French dictionary in the middle of Paris, it certainly helps you translate the menu at a cafe. But it doesn't teach you how to navigate the complex subway system, or how to negotiate a taxi fare, or how to truly survive in the culture. Is simply defining the disease, even thoroughly, really enough for a patient?
That is the exact friction point of modern health literacy. What's fascinating here is that defining the condition providing the phrasebook, as you said, is merely the gateway.
Just the beginning.
It is essential, but it is fundamentally insufficient for long-term survival and management. True understanding, the kind of understanding that allows a patient to actively participate in their own care, to question a specific dosage of a corticosteroid, or to recognize a dangerous drug interaction before it happens, that requires much more than a single document.
So what does it require?
It requires an entire ecosystem of reliable, ongoing information.
Which is the perfect bridge to examining the platform that actually built this guide, because a single document is only as trustworthy as the architecture behind it.
Absolutely.
If we've established how terrifying the physical reality of COPD is, and how easily a patient can be overwhelmed by the medical jargon, their first instinct is usually a panicked, late-night internet search.
We've all been there.
Right. But we all know what happens there. That usually leads to sponsored miracle cures, terrifying forum threads, or information that is secretly trying to sell you a specific brand of inhaler. How does a patient actually find a safe harbor?
That brings us to the core identity of iMedix, as outlined in our sources. The materials specifically define iMedix as an independent medical information platform that is staffed by an editorial and medical research team.
Let's hold a magnifying glass over that word for a second. Independent. In the context of health information, that word carries an enormous amount of weight, but it's also a word that is thrown around incredibly casually online.
Oh, definitely.
Every blogger with a vitamin supplement line claims to be an independent researcher. What does true independence actually mean practically, structurally, in the medical information space?
Practically, it means a complete structural separation from the entities that have a massive financial stake in your medical choices.
So, following the money.
Exactly. It means following the money and ensuring the information pipeline is fully insulated from it. Let's look at the alternatives. If an educational guide detailing COPD medications is sponsored, either directly or indirectly, by a major pharmaceutical company, say, a company that manufactures a patented, highly profitable brand of LAMA inhalers, there is an inherent, inescapable structural bias.
Even if they aren't explicitly lying about anything.
Right. The bias doesn't have to be a blatant falsehood. It lives in the subtle framing. They might subtly downplay the frequency of adverse side effects of their specific drug.
Or make it sound way better than it is.
Yes. They might frame their branded medication as overwhelmingly superior to older, cheaper, generic alternatives, even if the clinical outcomes are statistically similar. They might dedicate 10 pages to pharmacological interventions and only a single paragraph to pulmonary rehabilitation exercises.
Because nobody holds a patent on walking on a treadmill.
Exactly. There's no money in telling someone to exercise.
And what if the information comes from the other side of the financial spectrum, like a massive insurance conglomerate?
Then the bias shifts in the completely opposite direction. An insurance provider's implicit goal is cost containment. So their educational materials might subconsciously lean toward the most cost-effective, older treatments.
Creating friction for the newer stuff.
Right. They might minimize the visibility of newer, more expensive biologic therapies that might actually be the most biologically effective option for a specific patient.
So true independence is the complete absence of those specific financial gravity wells.
Yes. Independence is crucial for trustworthy patient education because it aligns the platform's ultimate goal solely with the patient's comprehensive understanding rather than a corporate bottom line.
The only product an independent platform is selling is clarity.
That's a great way to put it.
And to manufacture that clarity, the sources note they utilize this tandem structure, an editorial and medical research team. I find this fascinating because it implies that raw data just isn't enough. It takes two entirely distinct skill sets working together.
It absolutely takes two distinct skill sets, and the friction between those two teams is where the real value is created. Let's imagine their workflow for a second.
Okay, lay it out.
The medical research team is the foundation. They are the ones immersed in the clinical accuracy. They are parsing the dense, peer-reviewed, double-blind studies in pulmonary journals. They are looking at the intricate pharmacological data, understanding the precise half-life of a long-acting bronchodilator or the statistical hazard ratios of a new inhaled corticosteroid.
They are dealing with the absolute dry, objective, scientific truth.
Right, but if they just published that dry truth directly to the web, it would be exactly like the terrifying medical jargon the patient is trying to escape.
Exactly. Raw clinical data is completely impenetrable to the average layperson. It is hostile to learning.
And that is exactly where the editorial team steps in. The editors are responsible for the translation. Their job is to take that incredibly dense, mathematically complex clinical truth and mold it.
They shape it.
They structure it, they paste the information, they utilize analogies like our balloon and rubber band analogy from earlier, and they write it in a tone that is digestible, empathetic, and fundamentally useful to the end user. The researcher ensures it is true. The editor ensures it is understood.
Okay, but I'm going to play the ultimate skeptic here. Let's say I'm that terrified patient. I've just been diagnosed. I'm sitting at my computer at 2 a.m., the glow of the monitor illuminating my face, and I stumble onto the iMedix platform. I see the words, independent editorial team. Why should I believe them?
It's a fair question.
In the internet age, trust is at an absolute premium. How does an entity actually prove its value and its true independence to someone in a state of high anxiety who has probably been burned by misinformation before?
That is the most critical question in digital health literacy today. And the answer is that true independence is proven not by a flashy declaration on some polished About Us page. It is proven through the architecture of the tools they provide over time.
The proof is in the pudding.
Exactly.
Yeah.
It is proven by consistency, by depth, and by a relentless focus on objective mechanics rather than subjective promises. An inherently biased site pushes you toward a conclusion. A buy now button, a specific consultation, a proprietary supplement.
Right, they funnel you.
But a truly independent platform, on the other hand, provides a framework that empowers the user to do their own analysis. They give you the raw materials and the instruction manual, rather than just spoon-feeding you a predetermined narrative.
Which perfectly transitions us into the actual mechanics of how iMedix delivers on that promise. Because the source material highlights a dual toolkit that they offer. This is where it gets incredibly fascinating from an informational design perspective.
It really is unique.
The sources specifically highlight two distinct offerings that work symbiotically: the iMedix drug database and their educational resources.
It is a brilliant and highly necessary two-pronged approach to the problem of medical ignorance.
Let's dissect the distinction because it is vital. A drug database implies a very specific type of architecture. To me, it implies raw, searchable, highly structured data. It's the spreadsheet of modern medicine.
Yes, exactly.
If I go into a database and type in the generic name of a steroid inhaler, I am not looking for a warm, comforting story. I am looking for the chemical composition. I want the half-life. I want the known drug interactions. I want the exact statistical probability of specific adverse events. It is the uncompromising what?
Precisely.
Yeah.
The database is objective, clinical, exhaustive, and devoid of narrative. It's the raw data output of that medical research team we discussed. But as we've already touched upon, raw data without context is the absolute enemy of the anxious learner.
It creates a secondary trauma known as information overload.
Right?
If I pull up a LAMA inhaler, which is a long-acting muscarinic antagonist, used to keep airways open in COPD, and I just read the FDA-mandated list of 40 potential side effects, ranging from a mild headache to dry mouth to sudden cardiac arrest, my brain cannot process that list neutrally. It just doesn't know how to appropriately weigh those wildly disparate risks.
Human psychology in a state of fear zeroes in on the worst-case scenario. You read cardiac arrest and you freeze. You panic. You might decide the risk of the medication is worse than the disease itself, which is a catastrophic miscalculation.
And that panic is exactly where the second half of the toolkit, the educational resources, becomes vital. If the database is the spreadsheet, the educational resource is the breathing lessons guide. These resources provide the narrative, the historical context, and the synthesis.
Yes, the database tells you the what. The educational resource explains the why.
Right. It explains why this specific class of muscarinic antagonists is utilized for COPD, but might not be the first line of defense for a mild asthma patient. It explains how the medication structurally interacts with those inflamed airways and dead cilia we mapped out earlier.
Exactly.
So why are both strictly necessary? Because I can easily imagine a digital landscape where some platforms, maybe run by tech purists, only offer the hard data database, while other platforms, run by patient advocacy groups, only offer the friendly, narrative articles and the community support. Why does iMedix insist on housing both under one roof?
Because they recognize the fatal flaw in separating them. Educational narrative without the underlying accessible raw data lacks authority and precision. It becomes too soft. It risks glossing over harsh statistical realities in the name of comfort.
Right, it becomes fluff.
Exactly. Conversely, raw data without the educational narrative creates anxiety, confusion, and ultimately non-compliance with the medical treatment. They must exist in tandem.
Let's walk through a highly detailed hypothetical case study to really cement how this dual toolkit functions for a real patient in real time. Let's go back to that patient prescribed the LMA inhaler for their newly diagnosed COPD.
Okay, let's play it out.
They get the prescription slip from the doctor, they come home, boot up the computer, and go to the iMedix database. They type in the specific brand name. The database spits out the pharmacological profile, and right there, under adverse effects, they see a warning about urinary retention.
Which, in a vacuum, is a completely bizarre and terrifying piece of information. The patient is thinking, I have a lung disease. I am inhaling a powder into my chest to help me breathe. Why in the world is this drug threatening to paralyze my bladder? Is this medication toxic to my kidneys? Is it poison?
Exactly. Without context, it just feels like a random curse placed upon the drug by a vengeful pharmaceutical god. The instinct is to say, I'm not taking this, it's going to destroy my urinary tract. But then the patient toggles over to the educational resource side of the platform. They read an article specifically explaining the mechanism of action for muscarinic antagonists. What do they learn there?
They learn the biological why. The educational article explains that in the body there is a specific neurotransmitter called acetylcholine. In the lungs, when acetylcholine binds to muscarinic receptors on the smooth muscles surrounding the airways, it commands those muscles to contract and tighten.
Which is the literal last thing a COPD patient needs since their airways are already narrowed by inflammation.
Right, so the LAMA inhaler is designed to be an antagonist. It actively blocks those specific receptors in the lungs, preventing the acetylcholine from binding, which allows the airway muscles to stay relaxed and open.
Okay, that makes perfect logical sense for the lungs, but how does that connect to the bladder?
Well, the educational article would then explain that the human body is deeply interconnected. Those exact same muscarinic receptors that exist in the lungs also exist in the smooth muscle of the bladder wall.
Oh.
Yeah. In the bladder, acetylcholine binding to those receptors is what signals the muscle to contract and push urine out. Because the inhaled medication can sometimes be absorbed systemically into the bloodstream in very small amounts, it can inadvertently travel to the bladder and block the receptors there too.
Wow. So it blocks the contraction signal in the lungs to help you breathe, but by doing so, it might accidentally block the contraction signal in the bladder, making it harder to urinate?
Exactly. Suddenly, the side effect of urinary retention isn't a random mysterious poison. It is a highly logical, predictable, mechanical consequence of exactly how the drug is designed to work in the human body.
That is a massive paradigm shift. The synthesis of the rigid database and the contextual educational narrative completely bridges the gap between the specialized knowledge of medical professionals and the bewildered everyday patient. It transforms a frightening, arbitrary list of risks into a comprehensible biological mechanism. It demystifies the magic of the pill.
And that demystification is the exact philosophical heart of our deep dive today. We've spent a lot of time exploring what the platform offers, but we have to rigorously examine why it exists in the first place.
Right.
The source material doesn't just present these tools in a vacuum. It explicitly identifies a massive systemic societal problem that iMedix is actively trying to solve. The text states, people often misunderstand medication risks and why platforms like iMedix matter.
This brings us to the core disconnect in modern medicine, and it is a public health crisis of staggering proportions. Why are medication risks so universally, profoundly misunderstood by the public? We have more access to information than any generation in human history, yet we seem completely unequipped to process it. Is it solely the complex medical jargon we discussed earlier? Or is it the visceral fear factor of unfolding that microscopic piece of paper inside a pillbox and reading about your own potential demise in 6-point font?
It's a toxic combination of both fear and jargon, but it is ultimately compounded by a fundamental, widespread lack of statistical context and probability literacy.
We're just bad at math.
Human beings, from an evolutionary standpoint, are notoriously bad at intuitively understanding complex probability. We are wired to react to immediate anecdotal threats, not statistical hazard ratios.
Give me an example of how that plays out when reading a prescription label.
When a patient reads a standard FDA package insert, the legal formatting often forces the manufacturer to list literally everything that happened during the clinical trials. So the formatting might present a 1 in 10 chance of a mild transient side effect, like a slight headache or dry mouth, with the exact same visual weight, the exact same bullet point, as a 1 in 100,000 chance of acute liver failure.
To the untrained eye, they look equally likely to happen.
Well, exactly. The psychological burden of holding all those terrifying, disparate possibilities in your mind simultaneously, without a reliable mathematical framework to understand the actual risk-to-benefit ratio, is utterly paralyzing. You are forced to weigh the absolute certainty of your current suffering against the phantom possibility of a dozen different catastrophic outcomes.
It perfectly mirrors the modern experience of reading the terms and conditions on a major software update for your phone or computer.
Oh, that's a great comparison.
Yeah, people generally adopt one of two extreme behaviors when faced with that wall of legalese. Behavior 1. They blindly scroll as fast as humanly possible to the bottom and smash the accept button without reading a single syllable because they just want to use the new features on the app.
Which, while harmless for a photo-sharing app, is a profoundly dangerous abdication of responsibility when we are talking about ingesting potent pharmacological chemicals that alter your biology.
Right, and behavior 2 is the extreme opposite. Someone actually tries to read the terms, they spot one terrifying, overly broad legal clause like, this software reserves the right to occasionally delete all your localized files. and they absolutely panic, refuse to update the software, and leave their device vulnerable to security breaches. There is almost never a middle ground where a user calmly, rationally evaluates the actual probability of the terms being enforced. How do we find that rational middle ground with life-saving medication?
This raises one of the most important ethical and practical questions about how health literacy is currently managed in our healthcare system. Right now, the default system essentially hands a staggeringly complex, legally defensive pharmacological warning label to an untrained layperson and whispers, "Good luck."
It's totally unfair.
The entire burden of decoding the risk unfairly falls on the patient, usually when they are sick, exhausted, and least equipped to handle it. The middle ground you are asking for can only be achieved through active, deliberate translation.
We have to break the binary mindset.
Exactly. We have to systematically move patients away from the binary black and white thinking that a drug is either completely safe or inherently dangerous. There is no such thing as a medical intervention without risk. Even drinking too much water has a biological risk.
True.
The goal of platforms like iMedix isn't to promise safety. It is to provide the framework necessary to understand if the specific proven benefit to your specific condition mathematically and biologically outweighs the statistical likelihood of the risk.
And building that framework requires a structured approach. It doesn't happen by accident. Having identified this massive systemic problem of misunderstood risks and statistical paralysis, the source material provides a clear, actionable solution framework that iMedix operates on.
It's a three-part system.
Right. They distill their mission into a triad of focus areas: medication safety, treatment questions, and patient education. I want to deeply examine each of these three pillars because they form the ultimate roadmap for patient empowerment.
Let's reconstruct that triad, starting from the bedrock foundation: patient education.
This encompasses everything we've spent the last hour meticulously detailing regarding the COPD guide. It's knowing the what, the how, and the why of your own physical body. It's understanding the microscopic difference between the floppy, inelastic balloons of emphysema and the swollen, mucus-choked highways of chronic bronchitis.
Yes. The fundamental premise is that you cannot properly advocate for, maintain, or repair a machine if you do not understand how it operates. Patient education isn't about memorizing trivia. It is about building a robust, accurate mental model of your own biology and the specific pathology that is currently attacking it. Once you possess that mental model, you are no longer operating in the dark, and that foundational light allows you to move to the second, highly active pillar.
Treatment questions. I want to spend significant time emphasizing this point because this is where the theoretical becomes practical. Education in a medical context isn't just about passively receiving information.
No, it's an action.
It's not just reading an article on iMedix and nodding your head in quiet agreement. True education is defined by knowing which highly specific, targeted questions to ask your doctor. I think a massive percentage of the population goes into a specialized medical clinic, sits on that exam table, and just waits in silence to be told what to do. They assume the doctor will simply download the cure into their life. The ability to formulate good, analytical treatment questions represents a massive evolutionary leap in patient autonomy.
It fundamentally alters the power dynamic and the productivity of medical appointment. Let's compare two scenarios. The uneducated, passive patient comes in, breathless and scared, and says, "Doc, I can't breathe. Just fix it. Give me whatever works." The doctor, pressed for time, prescribes a standard, broad-spectrum inhaler, hoping it covers the bases.
It's a shot in the dark.
Exactly. Now, picture the educated patient who has utilized the iMedix framework. They come in and say, "Doctor, I understand my COPD involves both chronic inflammation in the airways and a loss of elasticity in the alveoli. I see you've prescribed a LAMA inhaler. Is this specific medication primarily targeting the inflammation, or is it strictly trying to force the airways open? And given my history of benign prostatic hyperplasia, should we be concerned about the muscarinic side effects causing urinary retention?"
That is a staggering difference. It's like a different species of patient. It turns the patient from a helpless passenger in a crashing plane into an active co-pilot in the cockpit, helping to read the instruments.
It forces the physician to engage on a higher level. It customizes the care instantly because the doctor now knows they are speaking to someone who comprehends the nuances of the treatment. And that collaborative, highly communicative approach leads directly and inevitably into the third pillar, which is the ultimate overarching goal of the entire system: medication safety.
Because safety isn't guaranteed just by FDA approval. Safety is an ongoing process.
Exactly. When you possess the foundational education, and when you utilize that education to ask the right targeted treatment questions, you statistically significantly reduce the risk of adverse medical events. You are vastly more likely to adhere to the medication schedule correctly because you understand why the drug needs to build up in your system over 2 weeks.
You see the logic.
You are more likely to spot dangerous overlapping drug interactions that a busy pharmacist might have missed. And crucially, you are more likely to accurately report early, subtle side effects to your doctor before they spiral into severe life-threatening complications.
Because you know the difference between an expected harmless side effect and a dangerous red flag. I want to ask everyone listening to pause and think about your very last interaction with the medical system. Think about your last doctor's visit, whether it was for a routine checkup or a major issue. Did you genuinely have the vocabulary, the biological mental model to ask the right treatment questions? Or did you just quietly take the printed prescription slip, nod politely, and walk out to your car hoping for the best? The entire thesis of this source material is arguing that independent platforms like iMedix exist precisely to arm you with those questions. They exist to build your vocabulary.
It is about fundamentally changing the baseline societal expectation of what it means to be a patient. It demands that we view patients not as a passive state of enduring illness, but as an active, engaged, intellectual pursuit of wellness.
Which brings our extensive journey full circle today. We covered an immense amount of ground. We started by looking intimately at a specific, deeply humanizing guide, breathing lessons, to grasp the terrifying physical realities of chronic obstructive pulmonary disease. We mapped out the devastating loss of alveolar elasticity and emphysema, the gross overproduction of mucus in chronic bronchitis, the toxic paralysis of the cilia caused by smoking, and the heartbreaking tragedy of patients ignoring early symptoms by blaming them on age.
From that microscopic view of lung pathology, we zoomed out to examine the macro architecture of the independent platform, iMedix, that authored the guide. We explored how their dual toolkit, utilizing both the uncompromising hard data of a drug database and the contextual, empathetic synthesis of educational resources, bridges the massive gap between clinical science and human understanding.
We deeply analyzed the systemic, psychological problem of how humanity fundamentally misunderstands statistical medication risks, leading us to the absolute necessity of patient empowerment through the triad of education, targeted questioning, and ultimate safety.
We traversed from the microscopic destruction of a single, delicate air sac in a failing lung, all the way out to the macro-level philosophical debates regarding global digital health literacy and structural bias.
So what does this all mean for you, the listener, navigating a complex medical world? It means that being well-informed isn't about perfectly memorizing thick, dusty medical textbooks or achieving a degree in pharmacology. You do not need to go to medical school to successfully and safely manage your health or the health of a loved one. It is simply about knowing where to locate reliable, structurally independent data, and more importantly, knowing how to confidently translate that raw data into highly actionable, specific treatment questions for your own unique life.
It is about recognizing that your health, your body, and your trajectory are an active daily pursuit, not a passive status bestowed upon you by a medical professional.
Exactly. And I want to leave you with one final provocative concept to mull over as you go about the rest of your day, taking those natural automatic breaths we've talked so much about. If independent platforms like iMedix are stepping up to essentially act as massive structural translators for complex medical data, specifically because the standard traditional healthcare system leaves everyday people fundamentally misunderstanding their own bodily risks and medication side effects, what does that deeply imply about the traditional doctor-patient dynamic we accepted for centuries? We have historically relied on a paternalistic system where the doctor is the sole, unquestioned keeper of sacred knowledge, and the patient is merely the grateful, silent recipient of instructions. But as you continue to navigate your own health journey, the landscape is shifting. Consider this the next time you're handed a diagnosis. Are you just blindly accepting the warning label and the prescription slip, hoping for the best? Or are you actively seeking the translation? Because, as we've learned today in excruciating detail, taking the simple act of breathing for granted is wonderfully comforting, right up until the exact moment that invisible machine breaks down. Make absolutely sure you have your phrasebook studied and ready long before you ever need it.